Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to Health Matters, a comprehensive chat, another episode in this Ramadan afternoon, a chat by the Islamic Medical Association, organization trying to empower you and educate you through this forum and many other forums. But we've had a good response from you throughout this Ramadan, and we've got Professor Mohamed Tikly here with us, rheumatology specialist from Chris Hani Baragwanath Hospital and Wits Medical School. Assalamu alaikum, Professor Mohamed.
Wa alaikum assalam wa rahmatullah, Dr. Yakub.
Jazakallah khair for coming. Alhamdulillah, alhamdulillah Rabbil Alameen, wal aqibatu lil muttaqeen, was salatu was salamu ala ashrafil mursaleen, Sayyidina Muhammadu wa alihi wa ashabihi ajma'een. The Prophet Muhammad said that for every joint in the body there is a sadaqah, and we should take out the sadaqah every morning. But that sadaqah doesn't have to be a material monetary one. It can be a tasbih, a la ilaha illallah, Allahu Akbar, alhamdulillah, inviting to good, forbidding wrong, or even a smile, or even 2 rakats of salah. So this sadaqah is obviously in the wisdom of the Prophet ﷺ, and we should try and practice this every day. And it's very appropriate to our topic. We will be talking about rheumatology, and I thought it would be a nice one to mention that for every joint of the body, there's a sadaqah to be taken out, and how easy it has been made for us. So inshallah, perhaps we can practice upon that, a very easy, practical way. Now moving on to the topic, Mohammed, obviously it's a very vast topic, rheumatic diseases, but the common one, one of the ones that I'd like to really start with and hope that you can enlighten us, is we see this often in our practice, is the topic of gout. Patients come to us and says, "Doctor, I've got gout," and they come with an acute inflamed joint, one joint, and they've come possibly with a history, or perhaps somebody else has told them that. But really, what is gout?
Bismillah ar-Rahman ar-Rahim, nahmaduhu wa nusalli ala rasulih al-kareem, amma ba'd. So thank you, Brother Yakub, for that question. Yeah, just to say that, gout is actually a very common condition. It's now probably ranked as one of the commonest rheumatic diseases that affects adults, especially men. What exactly is gout? Gout is actually what we would term a crystal arthropathy, a crystal arthritis. Now, the crystals are made up of a specific molecule called uric acid. And this shouldn't be mistaken to be stomach acid. This is a specific molecule also known as urate. Okay, and what happens in the blood is that just like in diabetes, where the sugar levels are abnormally elevated, in gout there's abnormal elevation of the urate or uric acid levels. And these crystals then deposit in the joints. And typically they deposit in the big toe, but can also deposit in the ankle and the knee, and sometimes the wrist as well. So it's an acute inflammation in response to the crystals being deposited in the joint.
So basically you're saying that it's uric acid levels that become raised, and then these crystals that are made up of urate get deposited in the joint, and they cause the inflammation.
That's right.
So who really gets gout?
Okay, so what's important to remember is that, and this applies to most of the rheumatic diseases, before we actually even see the patient, we take into consideration some of the demographic issues. And by that I mean we look at the gender of the patient, the age of the patient, and even the ethnicity. So if we look at gout as an example, gout almost never occurs in women before the menopause. So this is really an important thing, because often patients get uric acid levels done when they're premenopausal, and it's really not necessary, because it's very, very unusual to see that. In men, on the other hand, we don't see gout occurring before puberty. So typically gout occurs in the male who's usually in their 30s or 40s or a little older. In women, we only see it after the menopause, and the presentation is somewhat different.
So it's a predominantly male disease. And we have seen, obviously, in medical practice that there's an increase in the incidence of gout, but it just goes beyond the inflamed joint and the pain that occurs there. It's a much larger disease. It's got a bigger scope in terms of its complications, and it occurs with a very important element, which hopefully you'll be highlighting, is cardiovascular disease, and it's related to lifestyle. So
Absolutely.
Perhaps we can just give us some idea on what's going on there.
Yeah, so just first to say that in the old days they used to term gout as the disease of kings and the king of diseases. I don't think it's no longer either of them. gout actually occurs in poorer communities as well. And what we're seeing is with rapid urbanization and a rapid westernized kind of diet, we're seeing more and more gout in populations or in communities where it didn't occur. And just to give you an estimate that if you now look at people over the age of 65, probably 5% of elderly folk will develop gout. And there are a number of factors, and one of the important risk factors for that is high blood pressure. And the medication that we use for hypertension, particularly the water medications, the diuretics, especially the thiazides. So there are a number of factors. And of course, the other important risk factor is obesity. And of course, we know that many populations across the world are facing this challenge of obesity. So together with changes in our dietary habits, more sedentary lifestyle, the fact that we're living longer than in the past, all predisposes to this condition called gout.
So there's a link between lifestyle and gout and the things that you mentioned. But of course, the big thing that will come in is like the diet, right?
Yes.
Many times patients say, what can we eat, what can't we eat? Some are aware, some are unaware. Then there's a strong correlation between some foods and gout, is that right?
Yeah, absolutely. I think I should mention that there is a genetic risk as well. And so you'll see in many families, if one member of the families had gout, then usually there are three others. Yeah. Okay. We do see that. But having said that, I think dietary factors are important. And as I mentioned, in general, a high calorie intake puts you at risk. So obesity as a consequence of increased food intake puts you at risk for gout. But there are specific foods as well. And I have to say that in the last 10 years, the research that's been done on risk factors for gout have really cleared the sort of the muddy waters. For instance, in terms of what we knew about proteins, we used to say that any protein, whether it's animal protein or vegetable protein, puts you at risk for developing gout. What we now know from very large studies, community-based studies, that it's actually animal proteins, and specifically red meat. Now, of course, we knew about red meat, but these studies have simply confirmed that.
Yeah.
The other bit that we know is seafoods are also rich in purines, and purines are a precursor for the uric acid. So those are important sort of dietary risk factors. What we also know is alcohol, and it doesn't apply to our Muslim community, but alcohol is an important one. And again, with alcohol, it's been shown that beers are much more likely to precipitate gout than perhaps some of the other types of alcoholic beverages. There's also some interesting new evidence emerging that fruits that contain a high amount of fructose probably put people at risk. And it's been shown, for instance, that these low-calorie drinks that have high fructose content actually increases the risk of gout. And it might be that even the sugar-free fizzy drinks like the colas might also increase the risk of gout. So I think diet is an important thing. Obviously, for the person who has gout, controlling the diet alone is often not enough.
So there's a whole group of culprits in the food that cause gout, and those should be avoided as best as possible. And just to mention what Professor Tikly was saying, purines being the precursor, those are the little blocks at the molecular level, but basically at the end they get built into uric acid and become urate, and that gets deposited, and that causes your problems. But it goes beyond that, right? I mean, there's a link with lifestyle and cardiovascular disease. There's a link between uric acid and gout with lifestyle, and the two together are somehow related.
Oh, yeah. So I should add, in terms of protective dietary factors, that what we know now is that low-fat dairy products, such as yogurt, low-fat yogurt, is actually protective.
Oh, okay. That's interesting.
So, it's not all bad news about diet. But what I'd like to mention about diet and lifestyle-associated conditions, there is a common theme. Whether you were looking at heart disease, whether we're looking at diabetes, or in this case, looking at gout, it's one consistent message. Being overweight is not a good idea. Eating rich, fatty foods is not a good idea. Eating, red meat on a regular basis is not good news. It's not good for the heart. It's not good for the kidneys. It's not good for the joints. And I think that's the general message, that we can give one single message that if you take care of your diet, you're not only taking care of your joints, you're helping your heart as well. And what we know now is that gout actually is an independent risk factor for heart disease. And this is especially in men. So if you're a gout sufferer, it's not only a question of treating the gout per se, but it's also keeping an eye on the heart. A person who has gout doesn't mean that that person will develop heart disease, but is at increased risk of heart disease.
And he will have other factors in his lifestyle that complicate the heart disease. So it's a series of things put together, and not one single factor. But uric acid on its own is already a factor implicated in heart disease, and it has to be measured and be checked regularly in patients who've already got risk factors with the other cardiovascular diseases, even if they haven't had a swollen joint or a painful joint.
Oh yeah, absolutely. And similarly for kidney disease, it's been shown that progression of kidney disease in part is related to the uric acid levels.
And that's an interesting point when you bring kidney disease, because you've got high blood pressure which impacts on the kidney, and then the kidney itself can't excrete the uric acid, and then that can cause blood pressure to go up sometimes, and the heart itself. So there's a bit of a cycle between the whole kidney, blood pressure, and uric acid. Is that right?
And so we need to break that cycle by both medical therapy, in other words, dietary changes, exercise, and so forth, but also with medical drugs, with drugs in particular.
All right, and that's where another culprit comes in, right, Mohamed, is the drugs. We tend to just want to get rid of the inflammation, give them some non-steroidal anti-inflammatory like a Brufen or an Indocid, and then they get better and we feel happy about it. So that's the acute stage, and then obviously there's the controlling the long-term implications. But I want to get back specifically to Brufen and the non-steroidal drugs, which we use very often for many joint conditions and gout. You want to comment on that?
Yeah, so I want to make a point around anti-inflammatories in general and chronic use of anti-inflammatories. So we know that anti-inflammatories obviously help inflammation, but anti-inflammatories have been shown also, and this is good evidence now over the last 10 years, that regular intake of anti-inflammatories increases the risk of heart disease. Except for possibly naproxen or naproxen, all of them increase the risk of heart disease. But ibuprofen, Brufen, or Miprodol, whichever sort of trade name it goes by, Brufen in particular has a problem. So people who have pre-existing heart disease and who are on aspirin, if you are to take a Brufen tablet, right, it will negate, it will neutralize the benefit of the aspirin by acting on the receptor where aspirin works on platelets. So it's really important for people to realize that Miprodol and ibuprofen and all its sort of variants should not be used in people who have pre-existing heart disease and where the cardiologist has prescribed aspirin. The other anti-inflammatories don't do that. Now, in terms of the acute attack of gout, what we say today is we treat with a high dose for a short period with an anti-inflammatory. But in certain situations, we cannot use an anti-inflammatory, such as in a patient who's got peptic ulcer disease, a person who's got kidney disease, and possibly the one who's got a high-risk heart disease. And so we're very careful about, so it's not a question of just every time an attack occurs, we repeat the exercise of treating with an anti-inflammatory. What we should be doing is treating with the anti-inflammatory for 3 to 7 days, perhaps a little longer, and then address the underlying problem.
So we'll come back to the underlying problem. We just want to take a bit of an ad break, and then we're going to look at the underlying problem and the long-term control to try and minimize these acute attacks, which is main aim in terms of the long-term complications. So inshallah, we'll take an ad break, and then we'll continue discussion, and the lines will also be open for your calls, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters Comprehensive Chat by the Islamic Medical Association. We have Professor Mohamed Tikly here with us today discussing rheumatic diseases. We touched on gout. We're just kind of going to wrap up a little bit on the gout discussions as your calls come in. Inshallah, the number to call will appear on the screen at the bottom shortly, so get your calls ready. Professor Mohamed, we were speaking about gout, the acute attack. We spoke about the risk factors, why it's so important, how it's impacting on the heart, the kidney. But obviously all this means you've got to control it. One is the lifestyle control, but then we definitely need drugs to control. That's generally the scenario.
Right. Yeah, so what we need to do, like in diabetes, we use medication to bring down the sugar. In a similar way, in gout, we need to bring down the uric acid levels. Okay. So the way we do that is mainly by using a medication called allopurinol, or commonly known as Puricos. Now, I want to just make a point about the Puricos. Many people say when they start the Puricos, the gout gets worse. And that's actually true to an extent, to a point. Excuse me. And that's because during the initiation period of the Puricos, there's an imbalance in the blood with respect to the urate levels. And so you get that. And so what we do for the first 6 months, we always add colchicine. And what I do with my patients is to say start slowly with the Puricos. So start at 100 milligrams and then gradually increase. And we increase the medication until we reach the target of uric acid in the blood, which is 0.35, or some people say even as low as 0.30. Okay, and it's very similar in diabetes. In diabetes these days, we try to target for an HbA1c of 7. So this is the way we treat gout. We treat to target. Now, of course, along the way, you can have a few acute attacks, but as I said, with the colchicine, the risk of an acute attack is reduced. So what are the benefits of uric acid lowering therapy with Puricos? For one, you're going to have fewer attacks. Therefore, you're going to require less of the anti-inflammatories, or even in people who can't take anti-inflammatories, less of the cortisone. The second important thing is that those ugly tophi or lumps that occur around the elbows or the big toe, they tend to melt with the Puricos. The third benefit, as Dr. Yakub has mentioned, is that it probably benefits the heart in ways that we don't really understand. And then, as I mentioned, there's evidence now that if you have kidney dysfunction, if you have got early kidney problems, the rate of worsening of the kidney might be prevented with the use of Puricos. Now, there is a problem, and many patients will say, well, we get side effects. The side effects, or the allergic sort of side effects with Puricos, are extremely uncommon, probably less than 1 in 100. It is a problem. It is more of a problem in the elderly. I must say that if you do, and especially the elderly person who develops a skin rash when on Puricos, that medication should be stopped and the person should go immediately to his or her doctor, because a rash can be fatal if the medication is repeated.
Okay, so that's one of the serious side effects, but it's rare and it's more pronounced, or you'll be really aware of it in the elderly, but obviously it's not common, right?
Yeah, and again, we can reduce the dose to minimize that side effect.
Minimize the side effect. You mentioned colchicine. And we find a lot of the patients coming in, they take their colchicine when they get the acute attack. They obviously have a problem sometimes with the diarrhea that comes with it. But you said that we start with the colchicine and slowly upgrade the Puricos as we go along.
Yeah, so colchicine, we use it sort of in two situations. In the acute situation where you use a high dose, and that's when usually the diarrhea becomes a problem. Okay. Actually, in South Africa, our guidelines say we don't use colchicine. In the US, it's still popular, but there are problems with it. Often they say it makes you run before you can walk. Means you have the runs before you get better in terms of the joints. But we use it in a much smaller dose in the prevention of attacks. Okay. And that's when you combine it with the Puricos.
Okay. Just lastly, touching on gout before we move on, waiting for the calls to come in, the number is at the bottom of your screen. Is patients come in and the uric acid sometimes is measured while they got the acute attack, and then it comes back as a normal result, and then they say they don't have gout.
Yeah, you raise actually a very important point about the diagnosis of gout. So firstly, just to say that many people walk around with high uric acid levels. That does not amount to gout. So if you have if you have a sore joint and a raised uric acid level, that does not amount to gout. You could be just having pain for other reasons, okay? And we, generally speaking, just for an isolated raised uric acid, we do not prescribe Puricos. It's only if you have gouty attacks or you have some of the other complications like kidney stones and so forth. So as a rule, we do not advocate that every person who has high uric acid levels should be on Puricos. Rather, in that situation, we say do the dietary things, do the exercise, come down in weight and so forth. But the converse is also true, that in an acute attack of gout, somewhere between a third and 50% of patients will have a normal uric acid during the attack. And so we need to repeat the blood test, say 2 to 4 weeks after the acute attack. And invariably, almost always, in that situation, it will be raised. So don't be fooled by the fact that during an acute attack, the uric acid is normal. That doesn't mean you don't have gout.
So there's not much value in the uric acid value being normal when you got an acute attack. That's the take-home message. So don't take that for granted. It has to be repeated. Discuss it with your doctor, inshallah. The lines are open, 011-086-7700 or 1 or 2 or 3. You can call in to discuss your questions on rheumatic diseases. Doesn't have to be gout on its own. There are a whole series of rheumatic diseases that are common. We've discussed a common one that occurs in males, but perhaps now it will be very important to discuss another one that is much more common in females, and that's lupus.
Yeah, excuse the frog in my throat.
No problem.
Excuse
Seems
me.
to be. Yeah.
Right. All right. So yeah, we're now going to move over to lupus. So we've paid some attention to what is mainly a disease in men. We're going to talk about a condition that is much rarer than gout, but that occurs in women. And that is lupus. Now, lupus falls under the sort of broad category of what we call autoimmune diseases or autoimmune connective diseases. Just to say that autoimmunity is a term that we use to refer to those conditions where inflammation in the body occurs as a consequence of the immune system being directed against itself. The normal function of the immune system is to kill foreign organisms like viruses and bacteria. But for reasons that are not entirely clear, in some instances the immune system faces the wrong direction and it attacks itself. And that's why the term autoimmunity. And lupus is probably one of the sort of classic autoimmune diseases. It's a condition that we see mainly, but not exclusively, in young women, anywhere from the teens to the 30s and 40s. It's especially common in people of Asian and African extraction. And the reason it's particularly challenging.
Okay, we got a caller on the line, so we'll continue with the discussion just now. Assalamu alaikum. Assalamu alaikum.
Hello, doctor.
Hello. Go ahead with your question.
Yes. You know what? I went to the doctors. I've got gout for 4 years. They gave me tablets. Hello?
Yes, we can hear you.
Yes. They gave me the tablet. Another tablet. I forgot the name of the tablets. They are so big and white. So when I took that one tablet, I got rushed the whole body. So I went back to them again. They said they haven't got another tablet. It's only that tablet. So they never gave me anything till today.
So you're still getting your attacks of gout?
Yes, I've got gout.
Okay. Professor?
Yeah, well, firstly, just to ask you the question, what sort of age group are you in?
Sister, how old are you, sister?
Oh, I'm 61 now.
Okay, all right. So you certainly fall into the category where gout is common. Now, I think the big white tablet might be Puricos, all right?
Okay. Yes.
And what should be done is for the doctors to maybe give you a smaller version of the tablet or a lower strength. The big one is usually a 300 milligram tablet. And maybe in your case, if you just take 50 milligrams or 100 milligrams, that might not cause the rash.
Okay.
Yeah, of course, you know, the rashes can occur because of the other medication as well. So we can't necessarily blame the Puricos. But obviously, this is something your doctor needs to look at, whether it's actually the Puricos that's doing it or whether perhaps one of the other medications.
Okay, doctor.
Does that answer your question, sister? Jazakallah khair.
Yes, thank you very much.
You're welcome. Assalamu alaikum. So, Mohammed, you were talking about lupus. You had a point. We're talking about recognition, right? What and who. I mean, we spoke about what it is and now who gets it. You mentioned the young female group.
Mm-hmm.
And you would
Yeah, so I think, one of the challenges with lupus is it can affect many parts of the body, many systems, okay? But most commonly, it would start off as joint pains and a rash. And, the typical case scenario in a young patient is somebody who goes on holiday to a sunny place like Durban and comes back from the holiday, is feeling a bit feverish, goes to the family doctor. The family doctor says, I think you have a flu-like illness, but actually a month later you're still feeling lousy, and then you start developing this rash on the face and your joints start to swell. And then you start noticing a bit of hair loss, and that might be suggestive of lupus.
Okay, we have another caller. Assalamu alaikum.
Hi, my name is Peter.
Yes, Peter.
I just want to know, ask the professor, I'm on 100 milligram Puricos, and I just had a gout attack on Saturday. So I just want to know, do I stop the Puricos or do I carry on? And then can I take the anti-inflammatory first, and do I carry on with the Puricos?
Thank you, Peter. That's really an excellent
a very common question. Yeah.
So what we say is that if you're on Puricos during an acute attack, you continue with the same dose. If you haven't been started on Puricos, you don't actually start the therapy. So what we try avoid doing during an attack, acute attack, is alter the uric acid levels in the blood. Okay. So if you were to increase your allopurinol or Puricos, or to stop it, both of those situations would cause an alteration in the blood levels. So what we say is you continue with that same dose, you add on the anti-inflammatory. Of course, if you can't take the anti-inflammatory, then you might be given corticosteroids. But if you tolerate the anti-inflammatory, you continue with that. And usually, as you might know, between 7 and 10 days later, the acute attack will resolve. Right. Now, Right. Now, once the acute attack has resolved, say about 2 to 3 weeks down the line, you then need to repeat your uric acid level. Okay?
Right.
And if your uric acid is not in the target range of less than 0.35 millimoles per liter, okay, then you need to gradually increase your Puricos dose. Because
from
if you
the 100.
From the 100, excuse me, the frog's back. 100 milligrams is usually a starting dose. And for many people, 300 milligrams is sufficient. But in some instances, we have to go up to 700 or 800 milligrams of Puricos. So there is no one single dose that works for everybody. The point I made earlier is we need to treat to target. If you've got the tophi, the lumps, then in fact we say the target should be less than 0.3. Because we really need to dissolve those tophi. Okay, I hope that answers the question.
I just normally hear it in my big toe.
Big toe, yeah, well, that's fair enough. But the fact that you're having breakthrough attacks tells me that your uric acid levels haven't been controlled adequately.
So I made a mistake now, Professor, where I stopped the Puricos. So when do you suggest I go back on it?
When your acute attack has resolved, okay?
And I've got a,
Once it's resolved, and most times it's about 7 to 10 days later, right? And or up to 2 weeks, and then you start the 100 milligrams. But with that, you must start the colchicine, a half a tablet, 0.5 milligrams daily. Otherwise, you're going to get a recurrence of the attack.
So I take half colchicine with the Puricos.
Plus the 100 milligrams of Puricos. That's correct.
Yeah, Peter, sorry to intervene. There is a colchicine that comes as a 0.5 on its own. So it may not be half. So just see which one you're getting.
Great.
Okay, but it's a 0.5. But, just the final sort of comment is you need to do this in consultation with your doctor.
Sure. Thank you very much.
All right, so thanks, Jazakallah, for that. Thanks for the question. We're just going to take another ad break, and then you can call in again with your questions on gout or lupus or any other rheumatic disease. And we'll see you shortly, inshallah. Assalamu alaikum.
12 tablets.
Welcome to the world of Al's Hard.
It just shows an.
Are we back? Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters, a comprehensive chat by the Islamic Medical Association. We're having Professor Mohamed Tikly here discussing rheumatic diseases. We had quite a comprehensive discussion on gout. We've moved on to lupus, more common in females rather than males. The lines are open, so you can call. The number will appear on the screen below in a short while again. Mohamed, we're discussing lupus and the type of person that will get lupus, or generally. And then obviously the way to make the diagnosis after the clinical scenario in terms of the rash and the hair loss, the fever, some tests need to be done.
Yeah. So what I'd like to point out here is that, for most of the rheumatic diseases, there is no one single test that clinches the diagnosis, okay? We look at both the clinical picture as well as the blood results and sometimes the x-rays. Now, in the case of lupus, the test that we do is called the anti-nuclear antibody test, also referred to as the ANA test, also referred to as the ANF. And what I want to say here is that a positive ANF on its own is not suggestive of lupus. It has to be looked at in the context in terms of the clinical picture. Because there are many of us, up to 5% of healthy people, who will have a positive anti-nuclear antibody test and will never develop the condition. In fact, in relative first degree relatives of people who have lupus, about 10 to 20% will have a positive test but will never develop lupus. So really that's an important point to note.
Okay, so we'll continue the discussion. We just want to take the caller's question. Assalamu alaikum wa rahmatullah.
I would like to ask the doctor about rheumatoid arthritis.
Sure, go ahead.
Hello.
Go ahead, sister, we can hear you. Rheumatoid arthritis,
Yes,
what's your question?
I'm speaking from Mayfair, and I would like to know about the rheumatoid arthritis.
What would you like to know?
I have rheumatoid arthritis, and I'm taking pyrocaps and Celebrex, and I do have hiatus hernia, so is it good enough?
Are you taking pyrocaps and Celebrex together?
Yes, one in the morning and one at night, and I'm taking Losec for my hernia.
Pyrocaps is your Feldine.
Yeah. Okay. Can you tell us roughly what's your age, please?
68.
Yeah. So firstly, just to say, please, for heaven's sake, stop the pyrocaps.
Is it?
Yeah. Piroxicam in an elderly person like yourself is going to cause ulcers. And, it's not going to do much good for your joints. So that's the first bit of advice I can give you. In terms of the rheumatoid, I'm not sure how the diagnosis was made. Did you have
I had it done at the Johannesburg hospital.
Okay. Did you have swelling and stiffness of your joints?
I do have a lot of swelling and stiffness.
Yeah. So in 2014, we only use anti-inflammatories for relief of symptoms. Rheumatoid arthritis these days, we treat with a very different class of medications, okay? What we need to do with rheumatoid is to control the swelling and the damage that occurs to the bones. And unfortunately, Celebrex or pyrocaps, whatever anti-inflammatory you might be on, does not do that. And so we use a class of agents called disease-modifying agents. And the one that's most commonly prescribed is methotrexate, okay? Now, I want to just say, because we're on the topic of treating rheumatoid arthritis, I want to just make the point that methotrexate, although it was initially developed for the treatment of cancers, when we use it in rheumatoid, we use it in much smaller doses, and there is no issue around cancer and side effects of chemotherapy. I think it's very important because many patients do not want to take methotrexate on the basis that it's a cancer medication. When we use it for rheumatoid, it is to control the inflammation. And only drugs that modify the inflammation, like methotrexate, have long-term benefits. So taking pyrocaps For one, it's wrong because it's going to cause ulcers. The second reason is it's not helping your rheumatoid arthritis. So I think you need to discuss this with your doctor. If you indeed have rheumatoid arthritis, they need to change your medication in quite a dramatic way.
Doctor, can I tell you that they do give me methotrexate, and I was a bit apprehensive about it, so you think I should continue taking
Oh, absolutely. I think, just to say, I would be the first one to admit that methotrexate does cause side effects like nausea, you lose your appetite, and it causes headaches on the day that you take it or for the 24 hours thereafter. But it's well worth taking that or living with that little discomfort for a day or so. It really does make a difference. And, we were talking of heart disease. We know that rheumatoid patients are also at risk of developing heart disease.
Yes, yeah.
And what's been shown is that methotrexate, apart from helping the joints, also reduce the risk of heart attacks. So there are many benefits. And one way to reduce the risk of side effects of methotrexate is take it in the evening. So I say to people, take it over the weekend. Take it on a Friday night. So by Saturday morning, the side effects have worn off. And take it once a week only. So if you're prescribed 4 tablets, take at 8 o'clock at night. And then a day or 2 days later, you take your folic acid to prevent the mouth ulcers and some of the other side effects.
Oh, so they did start me on 7, and they raised it to 10. So is that a very big dose?
Well, it might be necessary. If your joints are still inflamed, then we do go up to 10 tablets a week. But if you're getting side effects, then obviously you need to talk to your doctor and then cut back the dose by 1 or 2 tablets.
I see.
So, sister, it seems like you didn't take your methotrexate, which was required. So go back and start the methotrexate and then cut down the other pain tablets, which you only need when you got acute pain at times.
So tell me, doctor, can't I take it like 1 at night every day? No.
What is that? The methotrexate?
The methotrexate.
Okay, so what we know is that if you take methotrexate daily, right, as opposed to taking it once a week, methotrexate causes more side effects to the liver and to the blood cells if you take it on a daily basis.
Oh, I see.
Okay, and just the other point, and it's for all the viewers, we never take 2 anti-inflammatories together.
Yes.
Okay,
Oh.
there is no benefit in taking a Celebrex with a Neprosyn or a Voltaren. You can only take one and one only, even if you are a younger person.
Okay.
And that also,
Jazakallah, doctor.
Barakallah.
Jazakallah for your call. And Mohammed, that also the anti-inflammatory only when you got acute pain at times. Eh?
That's right. Yeah, it's much safer to take paracetamol. My wife always says I'm a Panado doctor, but really, it does work.
Okay.
And it's a lot safer on the stomach and on the kidneys.
Yeah.
So try the paracetamol or the Paracords or sometimes the
Still
Stopay
pains and that.
before you go on to anti-inflammatories.
All right. So the message is pretty clear. The anti-inflammatories are quite dangerous. They don't really help in changing the disease. And at the same time, you just got to watch the side effect profile. We have another caller. Assalamu alaikum.
Wa alaikum salam wa rahmatullahi wa barakatuh.
Gee, what's your question?
Baba, I'm a 58-year-old male, and I've got a condition called polymyositis.
Right. What's your question?
The question is, I'm just trying to find out. I am on cyclosporine, prednisone, and Roshi 500. So I'm just trying to find out if I had 2 chemos done already, and I'm just trying to find out if there's any other way, because this thing is so. I mean, it's helping me, but I've got to live on it. So it's getting to me a bit.
Prof?
Okay, so
If the doctor, please help me.
Yeah.
If there's something else that I could do.
all right. So to start off with, just to explain what is polymyositis. Polymyositis refers to inflammation of muscles, okay? Not the heart muscles, but the skeletal muscles. And there are 2 types. One is polymyositis, where it only affects the muscles, but sometimes it can be associated with a skin rash, and that's known as dermatomyositis. Both those conditions, we treat them in the first instance with corticosteroids or cortisone, prednisone, which you've been taking. If the cortisone or prednisone does not work, then we add on what we term immunosuppressive agents, right? That is medications to suppress the immune reaction. Now, included in those, in that class of medications are methotrexate, azathioprine or Imuran. Okay, cyclosporin has been used, but it's really for the difficult cases. All right, and more recently we've been using medications like Celcept, and I'm just wondering the 500 Roche that you mentioned, whether that is actually Celcept or mycophenolate mofetil. That's the medication. The drip that you received was probably cyclophosphamide. Okay, and for the majority of patients, these medications do work. But there are some patients who don't respond adequately, who don't have a complete reduction in the inflammation. And that is a challenge. Now, there are some newer medications on the market. They're very expensive. They're called biologics. One of them is called rituximab or Mepthera. Not all of the medical aids pay for this medication, but it certainly does work for people or patients who have more resistant type of polymyositis.
Right. So I had two of the rituximab.
Right. Oh, so you've had rituximab and not cyclophosphamide. Okay. And has your power improved?
Well, for a little while, and then I did go back down again.
Okay. So how long ago did you have the Mepthera?
My last one was just before Ramzan.
Okay, so usually Mepthera doesn't work immediately, so I think you need to wait. If you've just had the first two doses, were they given 2 weeks apart? Is that how they gave you the Mepthera?
That's correct.
Right.
That's correct.
Yeah. So I think it's early days for you. Inshallah, you should start seeing a response in probably another month or so. I wouldn't change the medication right now. I think just continue. And inshallah, not everybody responds to the Mepthera, but certainly in our experience, most of the people do well on Mepthera. So inshallah, you would be one of them.
So brother, continue with your treatment, and where you're getting your treatment, just carry on with it and get it monitored. Is that right?
Yeah. And usually, if it does work for you, we don't have to repeat it less than every 6 months. Some people we've had responding to the treatment, and even 2 years down the line, they haven't required another infusion, another drip.
Okay, brother, inshallah, so we wish you shifa and you continue the treatment, and inshallah you'll get better and continue the advice the Professor has given you. We have one more caller. Okay, we're going to continue our discussion, and Mohamed, so we just were wrapping up on lupus. You were talking about anti-nuclear factor. It's not absolutely diagnostic of the disease. Right. So how do you make the diagnosis?
Well, we look for the features, and as I said, you get inflammation in the skin, so you get rashes, you get inflammation of the joints, so you get an arthritis. Sometimes there's inflammation of the kidneys, and that's obviously something to worry about. And so there'll be protein in the urine and blood in the urine. In kidney lupus, the important thing is to treat it very aggressively to prevent kidney failure. Okay. By the time we get to kidney failure, I'm afraid it's too late. Okay. And just to then quickly turn on to the treatment of lupus, and this is very important, that although we use cortisone to treat lupus, and there is no one single dose that we use for all of the different types of lupus. So for instance, for skin lupus, sometimes just topical steroids are good enough. For kidney lupus, on the other hand, we use high-dose corticosteroids or high-dose prednisone. But these days, we also use other immunosuppressive agents. And what we now know is that if you use cortisone for a long period of time in lupus, the side effects can become quite severe, more severe than the lupus
disease itself.
So one has to be very cautious about using high doses of prednisone for a long period of time. And when I mean high doses, anything about 10 milligrams a day.
Okay, so that's the message in terms of lupus. We would have liked to discuss a bit of lupus in pregnancy and other conditions, but time has run out. The lines are closed. We need to wrap up a bit. Perhaps, Prof, you can just give us a little bit of a summary. We've spoken a little bit about gout, lupus, maybe another take-home message into rheumatic diseases.
Okay, so just before I do that, just to say that the most important medication in lupus is actually chloroquine. Okay. So yeah, to wrap up then, to say that if you have joint pains that don't arise out of an accident or a motor car accident or trauma related, It's the swollen joint that should make you go to the doctor. You know, we all have aches and pains, but aches and pains on their own are not indicative of a serious rheumatic problem. Okay. The second point I'd like to make is that there is no single blood investigation, whether we're looking at rheumatoid or lupus or gout, there is no single investigation that tells us what the diagnosis is. It has to be taken in the context of the clinical picture. And x-rays are not a substitute. So if you're going to your doctor, you must insist your doctor examines your joint, not to refer you simply for a blood test or for an x-ray. Okay. And the medications, be careful with the anti-inflammatories, be careful with some of the other ones as well.
Jazakallah khair, Mohammed. That is a very interesting discussion. As usual, a lot to talk about. Time has run out on this Ramadan afternoon, the last Ramadan Sunday for us. We wish you well from the Islamic Medical Association for what is left of this holy month. May Allah grant you shifa for all your diseases and conditions. We wish you well over your health, both spiritual, moral and physical. And we will be returning back on our Tuesday slot week after. And we wish you a very good Eid, and Allah accept all your ibadah. And hopefully we'll be in touch again in the future with you as we continue to empower you through the Islamic Medical Association Health Matters, a comprehensive chat. Assalamu alaikum wa rahmatullahi wa barakatuh.